continuing our lesson where we are talking about three important practices which can educate and empower new parents to exclusively provide their own milk in the first 100 hours. Discussing the concept of the 8 or more milk removals in 24 hours is something that probably needs to be explained over and over in multiple different ways and then made clear through examples of what that looks like. Because it's very natural for our brains to hear 8 or more in 24 and divide that up into 3-hour intervals. That's a very normal instinctive thing to do. And it causes parents to assume things about what feeding is going to look like, which are not accurate. And therefore, when their baby wants to feed every hour, they think that something is wrong. We know that it's not wrong for newborns to want to feed frequently. We know that they need to feed whenever they need to feed. And if we go against that, if we try to put them on a schedule or a timetable of that, sometimes what happens is they're getting to the breast at a time where they're not really needing milk, or they're not actually in a space where they have the energy to do the feeding. So what happens is they have a shorter feeding than they actually would if the timing was right. So we really need to follow the baby's timings because, again, the baby is what drives milk production to synchronize to exactly what they need. So these milk removals that are happening in every 24-hour cycle ideally are happening with the baby breastfeeding. If the baby cannot, or if something is going on that is preventing the baby from doing the milk removal, then hand expression in the first 100 hours is completely sufficient to ensure that milk is being removed from the breast. It's a very gentle way. It's a very effective way to remove milk from the breast, especially when we have to feed that to the baby. Using a breast pump is different and actually produces different results than what we think that it does. So there's a recent study from 2024 where they looked at electroencephalograph activity, which is an EEG, during direct breastfeeding and breast milk expression in first-time mothers. Now, in this study, they were looking at the period later on in lactation, but we can extrapolate realistically to say that what happens during pumping is not the same exact thing as what happens during breastfeeding. If we think about those two things that way, we can say that hand expression is going to provide something that's in the middle. It's going to be something in between pumping and breastfeeding. And the reason that it does is because it's a different type of feedback that's happening in the brain. It gets milk out for the baby, sure. If the baby's not latching, the baby needs additional milk. It prevents the need to use costly equipment or have access to electricity for an electric breast pump. But also, it creates a different response in the brain and produces a different oxytocin response. So these things matter when we're talking about this early period of establishing milk production and establishing what should be happening for this dyad. During hand expression, there is tactile sensory input, warmth and touch, communication between the hand and the brain. So as the person is hand expressing, they are constantly making adjustments to what they're doing. They are being attentive to not causing themselves pain, but actually doing compression of the breast in a way that they could feel it. They are stimulating the milk ejection reflex, which means that oxytocin is being released. They are making milk available to the baby, and they're providing that feedback loop of being able to hand express milk. It feels comfortable when they're done. It feels like milk has been taken out of the breast, and it improves or it supports the hormonal signals of oxytocin and prolactin that are important for milk production, while also providing milk for the baby. Teaching hand expression, of course, requires patience, guidance, and practice. We can talk people through it, but it really helps if they can do it while we are talking about it and practice it frequently and see videos of other people doing it, especially if there are videos available of people who are doing it during the first 100 hours, when what they expect to see is simply drips of milk that is very thick and sticky, not necessarily milk that's spraying out in the beginning. Of course, if they've already surpassed the time where their milk is coming out copiously, it's important for them to see videos of that as well. If challenges are arising in the first 100 hours with breastfeeding in general, we want to encourage people to keep a simple mindset and simplify the process of responding to the challenges. Circle back to the basics. Remember that babies are better than, are greater than devices. Babies are the way to fix breastfeeding problems, especially early on. Always circle back to using breastfeeding as the intervention. It's the first line resolution strategy for challenges that are coming up in the newborn period. Whenever possible, circle back to breastfeeding, and then if needed, hand express and feed that milk to the baby as well. This is how we keep things simple. We don't require people to learn a lot of new skills or acquire a lot of new equipment. We just want people to be able to continue relying on breastfeeding, even if challenges arise, even if, for instance, jaundice happens, whatever is going on. We want people to rely on breastfeeding and add to it rather than seeing a challenge arise and leaving breastfeeding behind. If engorgement happens in the first 100 hours, we need to make sure that we, as lactation care providers and healthcare providers, are really clear on the fact that when engorgement happens in the first 100 hours, this is not the same as engorgement that happens later. This is a different phenomenon. We use the same word to describe it. It's really different, so the response to it needs to be different. What's happening during the first 100 hours is that milk production is increasing, but it's not yet regulated to what the baby is asking for. So it is not yet synchronized to the amount that needs to be made. What that means is that sometimes the body is making more milk than the baby actually needs, and that can mean there's a lot of milk in the breast. But we also know that it's very likely that the breasts are becoming engorged during the first 100 hours because IV fluids were given during labor and birth, or because of the excess fluids that remain in the body after birth. It takes time for the fluid levels to normalize. And when that excess fluid is collected in the breasts, as it does in other appendages of the body, like feet and hands, it's trying to get out. It's trying to find a way out. But it can interfere with how the ducts open up to let milk out. So engorgement during that time can truly be caused by other fluids other than milk. And that's why it's important to think about how we approach engorgement in the first 100 hours really differently than how we approach it later on. It's very likely that if engogement's happening in the first 100 hours, that we will need to instruct and educate the parent on how to use reverse pressure softening, gentle fingertip pressure on the areola back toward the chest wall that actually causes a softening that is noticeable. They want to do that just prior to latching or just prior to expressing milk. When all that excess fluid is there in the breast, it can block those ducts from being able to open up enough to let milk out. And by doing reverse pressure softening, gentle fingertip pressure back on the areola back toward the chest wall, this helps to move some of that fluid out of the way so that the ducts have space to open and let milk out through the openings in the nipple. Engorgement in the first 100 hours does not mean that the breasts are too full of milk. It does not mean that the baby won't be able to latch. And it does not mean that the mother or the parent needs to add in pumping. It does not mean these things. Now, this may be very, very different information than what people are encountering elsewhere in terms of what's available online, because most things that they see online are talking about engorgement that happens later. It's very important to distinguish what's going on with these engorged breasts during the first 100 hours. When they look online, they are going to find information that may be helpful, but it may be harmful because it doesn't ask them about what the root cause may be. It's not going to specify the difference between this early and later engorgement. So, what they are seeing may be encouraging them to use warmth or heat, may be encouraging them to put saline water in a silicone pump to help reduce the milk in there, or to add in pumping to their routine, or to pump more frequently, or to pump first before they try to feed the baby, or to use a silicone pump every time they breastfeed the baby. Because again, that concept that there's too much milk in there can be very confusing. It's really important that our structure of how we think about approaching early engorgement is really different and really gentle, because the goal is not to increase how much milk they're making. It's to make the breast softer so that the baby can latch and make it easier for milk to get out. So the ways that we do that, including how the milk is, or changing how the milk is flowing within the breast. So this can mean changing the position of how feeding is happening, change the orientation of the breast in relation to the breastfeeding baby. Basically, thinking about things like if they're using a position where the baby is in front of them and feeding, and the baby is lying on their side, say in a football position, or the baby is in a cross cradle hold and they're approaching the breast from the front, perhaps we want to move the baby to a side lying position so that the breast is in a different orientation and the baby's approaching it differently. Same with the way that they're pumping. If they're sitting up and pumping, they may want to try a different position for pumping, which allows them to lean back more or to lean forward more if they're leaning back. We always want to change the way that the breast is laying in relation to what's happening during milk removal in order to try to change that flow. So there are many ways to do this, and we want to encourage people to be creative and be, resourceful in how they do that. It may mean that to use their pump to help with the changing the flow of the milk, they need to lie on their side at the edge of the bed and let the bottles dangle downward. The breast is laying in a different way, milk can flow differently. The larger the breasts, the more impact we're going to have by changing how the breasts are laying. Because if you think about the way that what breasts do when somebody lays down flat on their back, they tend to, gravity grabs them and moves them to the sides. If the breasts are more firm, it's pulling breast tissue within the breast down toward in the direction of gravity. But when they sit up, the gravity is pulling toward the bottom of the breast, but not the top, or it's pulling those breasts out to the side, but not toward the nipple. So think about the way that the breast is in space, essentially, and change what's happening with the baby or the breast pump during that time in order to change that flow of milk. Try different positions. Also, can work on techniques to lift the breast tissue away from the wall, the chest wall, especially in those different positions, to help allow milk to flow differently. All these movements should always be extremely gentle. We're not trying to harm any tissues within the breast. We are simply trying to make changes to the way that the breast is in space so that it is able to get a different flow. Any kind of breast massage that's done on the breast at any time, but especially during the first 100 hours, should always be extremely gentle in sweeping motions that go toward the body, not toward the nipple. Sometimes people have an instinct to try to push milk toward the nipple because they think the breasts are too full of milk, push the milk toward the nipple, but that's not actually the problem. So what we want to see is that when people are massaging, it's very gentle in a sweeping motion that goes toward the body, not toward the nipple, comes back toward the body. It moves other fluids out of the way, again, to make space and allow the ducts to open up and let milk out. Deep massage can damage. It's very important to avoid deeply massaging or vigorous rubbing on engorged breasts, especially because these breasts are already experiencing some inflammation. We don't want to make that worse. Now, light touch, light, gentle massage, light, gentle brushing over the skin can increase circulation and reduce inflammation. The breasts contain very fragile tissue, so we want to handle them with care. Deep massage can damage, but light touch can relieve. Something else that has been found helpful in this specific study from 2021 was using a cold, wet compress of gauze that was soaked in Epsom salts. And it was applied, sort of wrapped on the sides of the breast for 10 to 15 minutes. It's an external application of Epsom salts, which are very inexpensive and easily accessible to many people. Lots of people do have it at home already. And in the study, they used gauze because in scientific studies, they want to use something that's, extremely clean. They can guarantee that it's sterile. In a home environment, somebody might be able to simply use a rag or a washcloth to soak in the Epsom salt solution, apply that to the breast, sort of wrapping it around, leave it there for about 15 minutes. If they want it to be cold or they want it to be warm because that feels better, the study did not look at that. It did not study the temperature, but it seems like something that people would just naturally do. And of course, the washcloth will come to the same temperature as the breast rather quickly. So it's a comfortable thing that seems pretty accessible and easily done for many people, affordable, accessible, something that people can try if they're feeling like their breasts are engorged, it's uncomfortable, and they want to be even more proactive about helping them to relax. So, our goal here with these three important practices is going to be circling back to basics and making it simple. Whatever happens, however complicated it starts to seem, we remain calm and we express that, we demonstrate that by reminding our clients, reminding our patients of the very, very simple cycle. Bring the baby back to skin, because things happen for you and the baby that we can't even see, but we know are important for their transition to the world from the womb, for their development, and for their breastfeeding. We breastfeed frequently and follow the baby's cues. Watch for baby's hunger cues because it's the only way for the baby to signal the body to make all the milk that they need. And we hand express. It provides more feedback to the body than a pump or other device does. It allows the breasts to be softened if they're feeling fuller, and it allows us to easily get milk into a spoon and easily get that spoonful of milk into the baby without having to worry about a complicated breast pump or anything like that. We want to use the simplest interventions to solve problems in the first 100 hours because these simple interventions, this very easy cycle to remember of what to do if there's a problem, helps to empower people and remind them, build their confidence that they can do this and that the answer to the issues that they're experiencing is to breastfeed, to get help with breastfeeding, and to continue to breastfeed so that they can continue to breastfeed. It's a really important cycle for them to remember. So the more we can repeat that, it's going to be easier for them to follow that process and to remember it, even when they're starting to struggle or become overwhelmed.